Hello, my name is Dr. Donald Warne. I am a member of the Oglala Lakota tribe from Pine Ridge, South Dakota. I'm a family doctor and also have training in public health. I'm currently on faculty at Johns Hopkins University in the Bloomberg School of Public Health, where I serve as professor as well as co-director of our Center for Indigenous Health. And today we'll be talking about American Indian data and data sovereignty as it pertains to maternal health. So very pleased to be a part of these important discussions, and I thank the Maternal Health Learning and Innovation Center for coordinating these important discussions. So for our discussion today, we'll look at definitions. We'll look at what is the definition of American Indian and Alaska Native, which is typically used in the US Census database. We'll also look at the definition of Native American and the definition of the term Indigenous. We'll also look at some key data sources so we can have a better understanding of where we get our data to assess the health of American Indian, Alaska Native populations as compared to other populations in the United States. We'll also have a brief discussion of American Indian and Alaska Native maternal health disparities. And then we'll also talk about the concept of data sovereignty. What does that mean from a tribal perspectives? And then also we'll look at next steps and considerations for how we could improve data, have better data coordination, and potential roles for the Maternal Health Learning and Innovation Center to improve some of these outcomes. So let's go ahead and get started with some definitions. We tend to see the term American Indian and the term Native American used interchangeably, but they actually have different legal definitions. So in the US Census as a database, the self-identified race is American Indian and Alaska Native. And when we look at the terminology, there's a reason why it's American Indian and Alaska Native, not just American Indian. So for purposes of the US Census, we self-identify our race or ethnicities. And the federal agency that defines the legal races and ethnicities that are recognized in the United States is OMB, the Office of Management and Budget. Why it is the OMB that does this, I do not know, but that's the agency that is responsible for determining the legally recognized races and ethnicities in the US. So in the United States, there's really only one ethnicity that's described, that's Hispanic. So an individual is either Hispanic or non-Hispanic. So that's why we see the term non-Hispanic white as a frequent designation for a race and ethnicity. The races, there's actually 5 of them that are recognized. There's white or Caucasian, Black or African American, American Indian and Alaska Native, Asian American, and Pacific Islander. So when we look at the American Indian and Alaska Native population as a race in the United States, these are the indigenous peoples of North America. So it really is the 49 states that are in North America as American Indian and Alaska Native. Now, when we look at the map of Alaska, in central Alaska, there's a large tribal group called Athabascans. And the Athabascan group is an American Indian cultural group. And actually even Navajos and Apaches in the southwest of the United States are Athabascan cultural groups. So in Alaska, Athabascans are both American Indian and Alaska Native. But when you look at other populations like the Inuit or Yupik populations in Alaska, they are not American Indian. They are indigenous, but they are not American Indian. So the Inuit population, for example, is more of a circumpolar population. So we have Inuit people who live in northern Alaska, but also in Siberia, Canada, and Greenland. So Inuit peoples are not American Indian, but they are Alaska Native. So that's kind of the definition of the American Indian and Alaska Native population. Within the racial group, we also have enrolled tribal members. And enrolled tribal members are more of a political designation, not a racial designation. And there are actually over 570 federally recognized tribes in the United States. And each tribe is its own political entity and has its own enrollment criteria to be a citizen. So as American Indians and Alaska Natives, we actually have a tri-citizenship in many ways. We are citizens of our tribal nation, citizens of the United States, and we're also residents of our states in which we live. So as a result, we're eligible for things like Medicare as US citizens and eligible for things like Medicaid as state residents, but we're also eligible for the Indian Health Service health programs as tribal citizens. So an enrolled tribal member is a subset of the self-identified American Indians and Alaska Natives in the US Census database. So I hope that makes sense. The US Census, it's self-identified American Indian and Alaska Native, but to be an enrolled tribal member is actually a political designation, and each tribe has their own criteria for tribal enrollment. Now, quite often we see Indian Health Service data just used synonymously with all American Indians and Alaska Natives, but actually the Indian Health Service serves a minority of the American Indians and Alaska Natives. So you have to be an enrolled tribal member, generally speaking, to receive those services. So many American Indians and Alaska Natives are not enrolled in a tribal group, so they're actually not eligible for Indian Health Service. In addition to that, there are people like me. I live in Grand Forks, North Dakota, in which there is no Indian Health Service facility. So for me to go to the Indian Health Service, I'd have to drive more than an hour away to find the closest reservation with an IHS facility. In addition to that, I have insurance, so I don't need to go that far distance to receive services. So as someone who's insured and living in a city, I can go to the private sector, which is what I do along with my family. So the IHS user population is the population of American Indians and Alaska Natives who have an active chart within the IHS. So that's having been seen within the IHS system within the last 3 years. So quite often we see IHS data sets as being representative of all American Indians, but actually it's not. If we look at data from the most recent US Census in 2020, there's 9.7 million self-identified American Indians and Alaska Natives. So we're actually nearly 3% of the US population, but the IHS user population is only about 2 million. So less than 25% of the American Indian Alaska Native population is actually captured in the IHS database. So something to keep in mind, that the IHS database does not reflect all American Indians and Alaska Natives. So we know the term Native American as well. And again, we see that term used interchangeably with American Indian, but it really is not. So Native American is actually legally defined as a term. In 1978, there was the Native American Programs Act, which defined Native Americans as American Indians, Alaska Natives, Native Hawaiians, and other indigenous peoples of US territories in the Pacific. So American Samoans are Native Americans. Indigenous peoples in Guam are also Native American. So if we say Native American, we have to be cognizant that we're talking about indigenous peoples of North America, as well as indigenous Americans in the Pacific Islands. So what's fascinating about that is that we're actually overlapping two OMB recognized racial groups when we say Native American. So Pacific Islanders are a separate racial group from American Indian and Alaska Native. So we have to be cognizant of this and be careful with our terminology. So when I'm talking about indigenous peoples here in North Dakota, I just say American Indian. It's interesting, I see a lot of people saying the American Indian and Alaska Native population in North Dakota. We have very few Alaska Natives who actually live in North Dakota. So I'm American Indian, and that's how I self-identify. Ironically, the term Indian comes from Columbus. Columbus thought he was in India. Therefore, we have American Indians, we have the West Indies, we have an Indian Health Service because Columbus thought he was in India. So it's not an ideal term, but it is the legally defined term. So that's looking at American Indian, Alaska Native, and Native American. The more encompassing term is Indigenous. And the indigenous peoples of the world are the first inhabitants of various regions of the globe. So we know through DNA evidence that human life started in Africa around 2 million years ago. And over the last 15,000 to 100,000 years, people have been migrating all over the world. And the original inhabitants of various parts of the earth are the indigenous peoples. And what we've seen over the last several hundred years is massive waves of colonization, primarily coming out of Western Europe. And what we see is when Indigenous peoples are colonized and then sometimes marginalized and lose access to their tribal or other community-based sovereignty and their traditional food systems, we see a very similar pattern of health disparities. So the Indigenous peoples of the United States, Canada, Australia, New Zealand, and other Pacific islands, we tend to see very similar patterns of health disparities, including things like diabetes, as well as maternal and child health disparities. So if I think about the data sources, there is the Indian Health Service, and it's a good data source for people who use the Indian Health Service. However, it does not capture all of the Indigenous peoples of the US, and certainly not all of the American Indians and Alaska Natives. So there are limitations to using IHS data. In addition, Indian Health Service has had challenges in appropriately sharing their data. So quite often it's difficult for a tribe to even get its own data from the IHS. So IHS is a federal agency located within the Department of Health and Human Services, and we do have challenges in terms of data sharing and data coordination. Obviously, another source is CDC, right? The Centers for Disease Control and Prevention. And within the CDC, of course, is the National Center for Health Statistics, and specifically a pregnancy mortality surveillance system. There was a wonderful publication released back in May of 2019 in the Vital Signs publication series, and it looked at pregnancy-related deaths in the United States and strategies for prevention. And this was really focusing on some of the significant health disparities that we see related to pregnancy-related morbidity and mortality. So it was one of the morbidity and mortality weekly reports. In addition, CDC, of course, has the CDC Wonder website with searchable databases to look at various types of health-related data. So CDC, in many ways, is probably a better data set for Indian Health Service because it'll capture American Indians that are not using the IHS. However, one of our other challenges with this data set is racial misclassification. And we've seen in a number of circumstances where American Indians are misclassified as another race or ethnicity, perhaps as white or Hispanic or Asian in some cases. So there's been a lot of work in recent years to try to improve data accuracy within CDC data sets. Based on a lot of the data sets, we did have a wonderful report that was released through the National Partnership for Women and Families, and it looks at American Indian, Alaska Native women's maternal health, addressing the crisis. And this was released in October of 2019, and I'll share some of the data that were reported there. Unfortunately, when we look at our disparities, they are quite significant. American Indian and Alaska Native women are 3 to 4 times more likely than white women to die of complications related to pregnancy and or childbirth. Isn't that remarkable? 3 to 4 times more likely than the white population to die from complications of pregnancy and or childbirth. In addition, American Indian and Alaska Native women are more than 2 times more likely than white women to have severe maternal morbidity, including preterm labor and obstetrical hemorrhage. In addition, we see greater rates of gestational diabetes and preeclampsia in American Indians and Alaska Natives. And there is a link to obesity, unfortunately, due to challenges related to food sovereignty and access to healthy foods and traditional foods. We do have a challenge related to earlier onset of obesity, including during the gestational years. And as a result, we wind up seeing higher rates of gestational diabetes and preeclampsia for American Indians and Alaska Natives. Another challenge in some of our regions, including here in the Northern Plains, is higher rates of smoking and substance use during pregnancy. There are a lot of regional differences, of course, when we look at the American Indian and Alaska Native population, but particularly in the Northern Plains, we see quite a few disparities. Not surprisingly, we also have a lot of infant mortality disparities. So I used to be on the board of trustees for the March of Dimes. And with the March of Dimes, we are looking at data related to both maternal and infant mortality and morbidity disparities. And in the state of South Dakota, we can see that the infant mortality rate is significantly higher for American Indians and Alaska Natives as compared to the white population. So 8.9 infant deaths per 1,000 live births as compared to 5.5 for the white population. And that's the state of South Dakota, where I am from originally. I'm currently working here in North Dakota, and the disparities patterns are very similar and actually even a little bit worse. So the infant mortality rate for American Indians and Alaska Natives in North Dakota is 9.4 per 1,000 live births, whereas it's 4.8 for the white population. So significant disparities in both maternal and child health outcomes. So when we're talking about data and American Indian and Alaska Native populations, we also have to be aware of the whole idea of data sovereignty. So data sovereignty is the idea that data are subject to the laws and governance structures within the nation in which it is collected. And we have to keep in mind that tribes are basically nations within the nation. And the concept of data sovereignty is closely linked with data security, cloud computing, network sovereignty, and technological sovereignty. But tribes are their own nations. So tribal data sovereignty is the right of a tribal nation to govern the collection, ownership, and application of its own data. So it derives from tribes' inherent right to govern their peoples, lands, and resources. So tribes are sovereign nations. Again, there's over 570 tribal nations within the United States, and each tribe has its own sovereign right to control its data. So I really like this quote from Dr. Stephanie Russo Carroll. She said, "Data are not a foreign concept in the Indigenous world. Indigenous peoples have always been data creators, data users, and data stewards. Data were and are embedded in Indigenous instructional practices and cultural principles." So I think it's important to acknowledge that Indigenous peoples, we've been doing data collection and analysis and research and evaluation for thousands of years. We just had different processes and different terminology for this area of work, but it's not a foreign concept to Indigenous peoples. This does create a challenge when we're using federal resources to collect data and to analyze data, because if it's federal money, then that's technically the property of the United States. So how do we deal with that challenge where we have the rights of the US to own data that it funds, but also the tribal sovereign rights to control its own data? So the NIH wants to share data. And that's because we need to advance rigorous and reproducible research. So we should be able to enable validation of research results and conduct similar studies across populations and then compare the results, make high value data sets accessible and usable, and having more data within large databases creates much more power in terms of the statistical value of the data. We could accelerate future research directions if we have larger databases with shared data from multiple sources. We can start to develop new interventions based on the data, have baseline measures, and then create interventions and study the outcomes. It's very important to do this. So also from an academic perspective, more opportunities for citation and collaboration by having shared databases. We also need to promote the public trust in research. In recent years, I think there's been a pushback against science and public health in some sectors, but we should try to build more public trust and have more transparency and accountability. Certainly, we spend a lot of taxpayer dollars through the NIH on research and data collection. We should maximize research participants' contributions. So if you participate in a study that then becomes part of a larger database, then the contribution to science is actually enhanced. But we also need to support appropriate protections of research participants' data. So we have to ensure that we have good practices in terms of protecting health information. So how can we limit the sharing of data? Because we would want to also respect tribal sovereignty and the tribe's inherent right to control their own data. So this is directly from the NIH, and some of the justifiable ethical, legal, and technical factors for limiting sharing of data include the following. It could be that the informed consent process will not permit or might limit the scope of sharing or use. There could be some research subjects who don't want their data as part of a larger database, and we need to respect the sovereign right of individuals to control the use of their data as well. There could be privacy or safety of research participants that could be compromised if there's insufficient protections of protected health information. There could also be explicit federal, state, local, or tribal laws or regulations that prohibit disclosure. So we have to respect the fact that tribal law could include limitations to sharing of data from its communities. And then some reasons to not generally justify limiting sharing of data is that the data are considered too small, not a large enough database. Researchers could say, well, we don't anticipate that the data will be widely used, therefore we're not going to share it, or data are not thought to have a suitable repository. So these are reasons generally not justified in limiting sharing. But an additional consideration is that the National Institutes of Health respects tribal sovereignty and supports reasonable management and sharing of American Indian and Alaska Native participant data. And I have a link here. If you go to the NIH website, there's an NIH tribal consultation report in which they share their draft policy for data management and sharing. So it's important to keep these things in mind. We have a multitude of data sets, but all kinds of considerations around how we use data, how we share data, and how we report data, because we have to be respectful of the sovereign nature of tribes. So when we think about this and the need for data coordination and next steps, we should support tribal data sovereignty by giving tribes more direct and easy access to data on our community. So we should promote tribal data sovereignty, but also promote access to data. And quite often the data sets are not easily at the fingertips of tribal leaders and tribal health stakeholders. So we should build capacity within tribes for using data for public health planning, grant writing, policy development, et cetera. So there's a real need to build tribal capacity, not just to collect its own data, but to use existing data sets and have access to them. So we really should maximize the use of existing data sets, especially data that has been corrected for American Indian and Alaska Native misclassification. And there's some really good data sets now that are cleaned, essentially, and making sure that we have appropriate racial classification. Another consideration is that we need to modernize data infrastructure to provide better services to tribes. And finally, support the mission to eliminate health disparities and improve the quality of life of tribal members. And when we look at the work that's going on nationally through this organization and others, these ideas are really consistent with the broader mission and vision of the organizations that are trying to promote maternal health. So perhaps moving forward and next steps, we could look at how our national organizations and advocacy groups around maternal health and maternal and child health could work collaboratively with the tribes to promote more access to data, appropriate data sharing, and being respectful of tribal data sovereignty. But at the same time, the long-term goal is to eliminate health disparities. Another point to keep in mind is that we do have a network of tribal epidemiology centers, and there are 12 of them located across the US. So most of the regions of the Indian Health Service have a tribal epidemiology center, and they have had various success in terms of accessing data from the Indian Health Service, data from tribal sources, and CDC data, and trying to compile those data with the purpose of developing and testing programs to improve outcomes and reduce disparities. So depending on where you are from, you can see which tribal epidemiology center is in your region where you work. Also, for those who work in cities, there is an Urban Indian Health Institute in Seattle that has an Urban Indian Health Epidemiology Center. So keep that in mind. You have an existing network of data partners and epidemiology centers that are already connected to the tribes. And perhaps that's an opportunity for those who are interested in coordinating with the tribes to get connected to some of that existing infrastructure. I always like to end these discussions with this particular image. Think about equality and equity. And the way I look at this, equality is kind of a one-size-fits-all approach. And everyone gets the same package of services, everyone has the same policies, everyone has the same programs, everyone has the same curriculum, whether or not it meets your needs. And that's equality. And we see that in things like our approach to sharing of data and data sovereignty. But we have to recognize that populations are different. And from an equity lens, what we really need is to ensure that we have the flexibility in our policies and our programs around data to ensure that we're meeting the needs of diverse populations. So I like this imagery, and with equality, you can see on the left, the guy on the far left didn't need that package of services. It's serving the one in the middle pretty well, but the guy on the right is still underserved. Whereas in equity, we're looking at outcomes and recognizing that we might need diversity of our policies and procedures and diversity of our approaches to meet the needs of diverse populations. So I had been showing this image for many years, and a couple of years ago, someone sent me an image that I think is just brilliant. And the question is, why is that fence there in the first place? And perhaps rather than just developing programs and policies to overcome the barriers, maybe we need to get rid of the systemic barriers. And when I think about that, there are so many social determinants of health, and there's a context that puts our population at greater risk for poor maternal health outcomes. One is the underfunding of the Indian Health Service. Indian Health Service is terribly underfunded and under-resourced. And as a result, we see things like later prenatal care, less public health services, less access to obstetrical care, and then worse outcomes. So do we need to develop policies and procedures to overcome the barrier, or do we just need to get rid of the barrier? And one way to get rid of that barrier is equitable funding of the Indian Health Service, and just to try to level the playing field. We also have to recognize that tribes are unique. There's not a single American Indian, Alaska Native culture or language. There's hundreds of tribes and hundreds of cultures. So we have to be cognizant of that. And I would recommend that wherever you work, that you do try to get to know your regional tribal nations and the indigenous population's history. Well, thank you so much. That's our module focusing on American Indian and Alaska Native data and data sovereignty. My email address is right here at donald.warne@und.edu, and I would be happy to answer questions should you have any following watching this particular training module. Thank you very much.